Okay. Thank you very much to the moderator, and thank you for the invitation to be here today. First of all, just a word on Giovan Battista Rossi, because I'm old enough to remember him very well, in fact, from the old days of the Gruppo di Cooperazione di Immunologia, which some of you might have attended years ago, Gargonza and other places. And then from Orbetello meetings when we had the AIDS, which was a key development in Italy on research, and certainly many of us, or some of us, but the young people here, remember this as a major change in how funding was in fact utilized in this country. And I have other memories too, but these are more personal, and these I share with Giovanni's wife and the family. Having said that, I thank Filippo for his invitation. I mean, when he asked me, it wasn't very simple. I mean, we're not using interferon, we're talking about alpha, that much nowadays. So I came up with this title that reads, What Interferon Has Meant to Hematology and What Hematology Has Meant to Interferon, because I think this is an interesting story that some people may not remember. I might change the presentation, but this could be embarrassing. Let me see if I get the right one out. Yeah. All right. A bit of history of medicine, in fact, this is. Now, when I go and talk about the changes that we've witnessed in the management of hematological conditions over the years, one of the slides is like this, maybe not in red, and I put obviously the changes in acute lymphoblastic leukemia in children and other diseases. Acute promyelocytic is a typical example of how targeted treatment is today a reality in our world. But I do remember two settings where interferon has had a major role, and in particular the story of hairy cell leukemia. Now, I think there are people here who are very young in the audience and certainly don't know the story. Now, interferon started many years ago, and that was before the DNA recombinant story, and it was produced in large cell cultures. And at some point it was in Red Cross in Finland, and based on preclinical data, it was seen that there was an anti-tumor effect, and it went to the clinic and was attempted in many different tumors with no result whatsoever, disastrous results, toxicity, too high doses. The story was that IFN-alpha was going to be abandoned as an anti-cancer drug. We're talking about 30 plus years ago. Then, for some very strange reason, and probably totally obscure reason, one patient with a hairy cell leukemia was put on a lower dose of interferon. Now, details of that I'm not sure about, but that was a fact. And this patient responded. So that is, in one side, how it changes history of interferon. The other is how it changed the history of hairy cell leukemia. So that's why I put it in red up there. And it opened the use of interferon not only in hematology, but certainly in cancer in general. It had a major role in chronic myeloid leukemia, as many of you know, and I'll spend a bit of time on that, and in other situations too. We talk a lot, for instance, about chemoimmunotherapy in non-Hodgkin lymphomas. You see it down here. But this refers nowadays to chemotherapy plus rituximab, anti-CD20, but the whole story, in fact, started years ago with chemo plus interferon-alpha. We tend to forget it, but that is a bit of history. So let's go. This is a paper, in fact, I put it in red up there, 1984. So this is by chance. We're celebrating the 30th anniversary, in fact, of the study that demonstrated that interferon-alpha could work in cancer. And this was a study done by the MD Anderson group, in fact, in hairy cell leukemia. I'm not going into detail, but there were patients with progressive hairy cell were given partly pure interferon, not recombinant. This was the older days. Intramuscular, 3 patients, there were 7 patients altogether, 3 patients had a complete remission. These are progressive hairy or relapsed hairy cell leukemias. And 4 the partial remission. I'm not going into detail, but you see that remission were maintained for over 6 to 10 months, and therefore this drug appeared to be highly effective in patients with hairy cell leukemia. That was a revolutionary observation. And to make a long story short, it changed the natural history of hairy cell leukemia. Before that, it was splenectomy, chemotherapy. After that, for many years, it was interferon, and that's what we gave. Then other things have changed, and something is in the next slide here, where you can see this is from a more recent study, exactly 30 days later. It's a review on the management of hairy cell leukemia, starting from what it was selective interferon-alpha historically. And then we went, it's a fascinating disease, it's a rare disease, mainly affects males, doesn't exist in children. Very strange disease. It responded beautifully to interferon. Don't ask me why, because we don't know, but that is a fact, as often happens. But then it responded very well to other drugs. And very interestingly now, last 2 years, 2.5 years, we found a BRAF mutation. You've heard about BRAF in melanoma by two of the speakers. Now an Italian consortium, I'm happy to say, funded by IFN, Italian Center Against Cancer, found that hairy cell leukemia patients, practically all the classic forms, have a mutation of BRAF. And in fact, the anti-BRAF has been used and the study is closed, not yet ready for publication, will be presented probably at the EHA in June. So again, very interesting development in this disease, but it started with interferon years ago. Non-Hodgkin, just to give you an idea, this is in follicular, so let's say more indolent lymphomas. This is chemotherapy plus interferon. I'm again not going into details. It's an old study again, 98, JCO. You can see addition of an immunomodulatory agent that does significantly increase the effect of chemotherapy. Historically, chemoimmunotherapy goes back a rather long time. It comes before rituximab. This slide is in Italian, but it doesn't really matter. Just to say that interferon can be used in other myeloproliferative disorders. I'll come to CML in a minute. In essential thrombocytopenia, in thrombocytosis associated with other diseases, and in polycythemia vera. Also, the pegylated form is highly effective, and this you can see doesn't only go back to the old days. You can see here this is reported in recent publications, so still a role in other conditions. And these are guidelines published in 2010, so not that historic, showing that the guideline for investigating and managing adults and children presenting with a thrombocytosis, and you can have different conditions where you find a thrombocytosis. You can see, for instance, a young patient and those contemplating pregnancy, interferon is a reasonable treatment option. Interferon is a useful agent for treatment of essential thrombocythemia, although it may be associated with more side effects. The pegylated is certainly effective too. So there are many indications that are still valuable today. Now a few words on chronic myeloid leukemia. This is the other hallmark of change in management. Hairy cell was the first. That opened the way. It was really, I think, a break in development. And then in chronic myeloid leukemia. Now in the old days, chronic myeloid leukemia treatment was chemotherapy and a transplant. If you had a donor, if the patient was eligible, etc., etc. Now interferon, old study, this goes back again a long time, but showed that interferon alone is better than chemotherapy. So that was obviously good news, because if you can avoid chemo, it's obviously good news, although interferon has side effects, but still. And this difference was highly significant. So interferon, again, has changed the natural history of a leukemia, of a cancer, CML. And that is open to many developments in CML. Now, biological data too, these are CML patients in chronic phase have a depleted dendritic cell compartment and impaired interferon alpha production. And you can partly saw this by giving interferon. I don't have time, but these are data that we've known for some time. Now this is a much more recent study. You very well know that over the years, targeted treatment in hematology started with acute promyelocytic leukemia and then developed in CML with the tyrosine kinase inhibitors. It's been revolutionizing the approach to chronic myeloid leukemia to an extent that we very rarely transplant a patient. Could there be a role for interferon? Well, this is a French study, recent, published in the New England 2010. There's a molecular response. Again, you see that there's a superior molecular response if you add pegylated interferon to imatinib, Gleevec. You can see that there is a difference which is significant. So you're adding to the effector tyrosine kinase inhibitor. This could be valuable. I don't have time to go into this, the study is ongoing, but now the end point of the study is to see how many patients can obtain a close to zero molecular level and stop tyrosine kinase inhibitors for toxicity, for cost reasons, and etc., etc. So this is a combination, I'll show you at the end, that is being investigated. Other studies showing the combination of interferon and imatinib, French, the Nordic group, German, the MD Anderson, and many studies, and more or less not with totally agreement, but there is indication that you can improve with the addition of interferon. again in Italian, but I didn't have time to change, just to give you an idea how things can happen. I mean, it's not a study, just a single patient that we've been following in the institute, in fact, much before I came down to Rome. So this patient was diagnosed with CML in 1983, so that's more than 30 years ago. In 85, because in those years the only chance of cure was an allogeneic transplant, he underwent an allogeneic family donor transplant. In 87, he showed a cytogenetic response and started on interferon-alpha 10 million 3 times weekly. June of 88, he obtained cytogenetic remission, and he continued with interferon for years. This is April 94. He starts a molecular analysis. In the old days of cytogenetics, that's a bit of history of how things developed. Then we went to PCR monitoring of the BCR-Abelson. So he started to undergo molecular monitoring, which proved positive. So he started again on interferon 5 days a week, and the marrow is monitored regularly. And the last control, you see July of 2011, November of last year, you see very, very low copy numbers of the BCR-Abelson, almost negative. And I added here, he has always refused to move on to TKI inhibitor. This is an individual decision. It was obvious that we proposed to go to an inhibitor. This is obvious. He refused to he was happy with his interferon, and he's going on for 31 years, transplant interferon, and he's doing very well. I'm going to the end. This is just to show you a current study. This is, in fact, it's Andreas Okar's personal communication, just to show you where we're going, putting together new and old. There's a first-line treatment for CML, nilotinib, second-generation TKI inhibitor, induction, continuous, so it's induction plus maintenance with nilotinib and follow-up. Here it's instead induction with nilotinib and PEG interferon, and then maintenance is not with nilotinib, not with TKI inhibitor, but with the interferon. And the aim is exactly here, cure, question mark. See how many patients can be induced into molecular remission, and can indeed interferon increase based on what had been preliminarily seen in a large randomized study. This is ongoing, so I have no idea, and we will see. But this gives an idea of how we are linking the old to the new. And in terms of the new, I just rapidly, well, in the last few hours, pulled down a few recent publications of last year and say first month of this year, referring to interferon. Here's enlarged memory T cell pool and enhanced Th1 type response in CML patients who have successfully stopped interferon. So there is an effect even after stopping. Long-term outcome of Philadelphia positive CML patients achieving complete cytogenetic remission with interferon-based therapy, moving from interferon to imatinib. There's another study, the tolerability effects of pegylated interferon in combination with imatinib for patients with chronic phase. This Cancer 2013. Another paper just came out, in fact it's only online, imatinib plus pegylated discontinuation. A key point, how many patients? This is a very important point clinically and even in terms of costs. Then not only chronic myeloid leukemia, there's a study from Saudi Arabia, PEG interferon with low-dose ribavirin for treatment of hepatitis C virus infection in patients with sickle cell anemia, very frequent in that part of the world, in the Gulf area. Another important study in adult T-cell leukemia lymphoma where interferon is one of the most active drugs, even today. This is a 2013 study. Long-term response in Danish patients with essential thrombocythemia, polycythemia, and myelofibrosis were recombinant interferon, again last year. And interesting here, depletion of JAK2, myelofibrosis neoplasm propagating stem cells by interferon-alpha in a polycythemia. This came out early, leukemic stem cells. This is a key point for targeting the higher stem cell, leukemic stem cell. And then this is a review of Moshe Talpatz, MD Anderson, one of the pioneers in this area, re-emergent interferon in the treatment of chronic myeloid leukemia. So this, I think, Philippe asked me earlier if we're going ahead with it. It's not only history. I think the history is very clear. I think there's still role for it, even in our condition, even at a time when we're actually working on targeting therapy, identify new mutation. I think there's a role for this. CML there is. I reminded that we're using inhibitors for Philadelphia positive ALL, and we put all patients in remission without chemo. Nobody's ever studied the role of interferon-alpha in those patients in remission. This came to my mind early, could be considered. We will see. Final, just to remind myself, I didn't even know, you will know because you're the expert, that this is a book on interferon that comes from the story of interferon from From the old days, in the Finnish doctor, Kari can tell the story I mentioned of the supernatants in the Finnish Red Cross, were in fact he was one of the main authors in the 60s, so very old. And this led to the story that I told you of the first studies in vivo. So I'll stop here, that's it, and thank you very much.
Thank you. Next question.
There is a group in Antwerp that is using regulated interferon for acute myalgic leukemia, for which there has been no treatment. And they reported several remissions, and I spoke with them on the phone, and they were very optimistic. Do you have any data at all about interferon? And they say again, sort of re-emergence of interferon using the pegylated form in the acute myelopathy.
Yeah, I heard a bit about that. I mean, we don't have experience, and I find it difficult. I mean, it depends. We have to see in what setting was this given, because in a florid acute myeloid leukemia, I would find it difficult to believe that you could activate the immune system to control acute leukemia. Whether this could be done in a setting of minimal residual disease, that could make maybe more sense. But I mean, what is data published?
Yes.
It be published. But in a large study, or because I don't know of any large study.
They were isolated.
Okay. Because I don't know of any large study investigated interferon.
They were isolated cases, and they were republications. In fact, I contacted them for personal reasons,
Right.
because I had a friend
Yeah.
who developed acute myalgic leukemia, and so I spoke with them. These are isolated cases.
Exactly, yeah.
And that's why I wanted to know whether you knew of any.
There are no large studies that have been conducted. The point is that even in AML, even more so in ALL, there are many more drugs now that are effective. So we're controlling many more acute leukemia patients with quote-unquote conventional treatment. So that's why probably no large study has been conducted. Now, whether this could be incorporated in given settings, now we can monitor the disease much more precisely. So you could consider minimal residual disease incorporating an immune modulator. I mean, if you look at the story of maintenance treatment, we've learned from interferon. I didn't have time to show it, but myeloma. One of the old studies was done in myeloma with interferon, published again in New England many years ago, showing a role of maintenance. Now maintenance has been utilized in myeloma with lenalidomide, for instance, again another paper in New England. So the issue of maintenance and the potential role in another cancer is myeloma, started with interferon years ago. It hasn't been addressed in acute leukemia so far.
Okay, I have just a question about in the first 3 or 4 slides, you showed that the PEG interferon was less toxic than the standard interferon. And I am quite surprised about that. Obviously, we have to discuss about amounts, the type of the inoculation, but it is really unexpected, because in the other disease, we always record a more toxic effect of the pegylated.
That was one study. So it's not across the board, and as you said, that you have to compare those with those. I mean, even with the old way of administration, I mean, it started with high dose, and then we learned over time to reduce it always more. So it's hard to compare, and it's used much less now, at least in our field. So there are not many studies comparing.